Hello and good evening, everyone. Welcome to tonight's New Teeth Now webinar. I'm Shauna and I'm with you tonight, joined by board-certified oral and maxillofacial surgeon, Dr. Harley Richards. Hi, Dr.
Hi,
Richards.
Shauna. How are you doing?
This is my first webinar. Never done this before.
You're doing a great job.
So far, so good. So, Dr. Richards, our audience is looking for an implant professional. I'd say an expert in what we do,
Right.
being New Teeth Now. Why don't you tell us a little bit about yourself?
Well, myself as well as oral surgeons in general, we have a lot of advanced surgical training in the facial area. An oral surgeon is a dentist. In my case, I graduated from Emory Dental School in 1976 and then did a anesthesia fellowship for a year. And during that time, all I did was anesthesia in a hospital operating room. And we had a great time doing that, learned a lot.
Yeah.
And following the year of anesthesia, I did a 3-year oral and maxillofacial surgery residency. And this was all up at what was then the Jacksonville Hospital Educational Programs, which is now Shands Jacksonville. So after 4 years of college and 4 years of dental school and 4 years of post-dental school residency, I came to Lakeland in 1980.
That's right.
Ready to rock and roll.
There you
So
go.
implants were just coming over from Europe about that time. The Brandemark series of implants came over in about 83, 84. And so I've been placing implants and since in that time frame, since about
1980.
83, 84.
I was born in 81.
Yeah.
There you go.
Yeah, it's been a long time. I've been here in Lakeland. By the way, I grew up in Lakeland, and so I've been back in Lakeland, and this summer will be 38 years in
Wonderful.
practice here.
Wonderful. Well, let's get started. Our audience is here tonight to learn about New Teeth Now, which is an excellent service that we provide patients who are looking to replace their dentures or maybe their failing natural teeth. So let's talk about that. What is New Teeth Now and what do we do here?
Well, this is a procedure, and what the viewers need to understand is there's pre-planning that goes into this process. And I'm going to start after the pre-planning and take you through what would happen to a person who's been seen for a consult, who's been seen by our restorative dentist, who we have already gotten a medical clearance for general anesthesia from their physician, and they show up at our office at about 7:15 on the day of their procedure. So we'll start there.
Okay.
We have 2 nurse anesthetists who administer the anesthesia, Kim Cherry and Patrick Daniel, and they would greet this person and take them back to the operating room. There they typically do a little bit of kind of an anesthesia interview and talk about medical history or what type of anesthesia experience maybe the person's had in the past. They start an IV, they put the person to sleep. After the person is asleep, we drape everything out. We do our procedure, which would involve removing teeth if there are teeth. If there are not teeth, then we just place the implants. I'm not going to go into all the technical aspects of that. Once the implants are placed and the tissue is closed, then we take impressions, and we take the records that we obtained during the procedure, combine those with the records that Dr. Dibbs, the restorative dentist, has already taken prior to the procedure, and our in-house laboratory, which is primarily for the purpose of this type of restoration only, creates an acrylic temporary bridge that afternoon, which we place into the person's mouth that afternoon, whether it is an upper, a lower, or both. And of course, by that time, the person has completely awakened from the anesthesia, and they're able to go home.
Wonderful.
So they come in with a mouthful of bad teeth, and they leave with a mouthful of implant-supported bridge work.
A brand new restoration.
Right.
In a one-day surgery setting.
Right.
So the slide that's up now is basically showing us how the implants are installed into the bone with the prosthetic.
Right.
So let's talk about the prosthetic and the implants.
Well, the initial prosthesis or bridge, whatever, a bridge, there are bridges in dentistry, and basically it's a set of teeth that connects other teeth. Or in implant dentistry, there's a set of teeth that connects all of the implants. And so this is a bridge, and this particular bridge is connected to implants. We do a provisional or a temporary bridge as the first measure because it's easy to make in one day. And our patients wear that for 4, 5, or 6 months, and then the final teeth are made. Mm-hmm. And the final teeth are made out of a very durable material, zirconia, and then the zirconia has porcelain added to it for coloration of the teeth and the gums.
You had held up this model. I'd like to do that again just to show our audience, a real look of what the bridge looks like. There is some artificial gum on the bridge, correct?
There will be varying degrees of artificial gum depending on how much, let's say, bone loss the person has had.
Yes, sir.
If they have had advanced periodontal disease and they've had a lot of bone loss, then there will be more artificial gum tissue to fill in, because the teeth have to be the size of normal teeth. And so then you have to have gum tissue to fill in the difference between the size of the teeth and where the person's own natural gum tissue is.
Right.
So that will vary greatly based upon the individual's circumstances.
And it's very different from a denture. It's palateless, so they can fill their palate.
Right. This is a bridge. This is not a denture. A denture would be a large piece of plastic that would fit across the entire upper, covering the palate. And this is a bridge. There you go. You can see that pretty well. There's little holes in the bridge because screws attach this bridge to the implants, and the access to the screws is through those little holes. There's like a little screwdriver. On the opposite side of the bridge, which is the side which is adapted to the tissue, there are titanium cylinders that interface with the implants. And then this is a solid milled zirconia bridge onto which porcelain is added for the coloration of the teeth and the artificial gum tissue.
And it's not removable.
That's a good point. This is screw retained. Once it is screwed in place, you are not able to remove it. Now, we are able to remove it by loosening the screws and removing the screws, and we can take it out. For if a person comes to us to have their teeth cleaned, we unscrew their teeth and remove them and clean them and then put them back in.
Wonderful. So, basically it would restore their function, help restore their confidence. No need for adhesives. It can be maintained pretty much like natural teeth.
Right. The maintenance, a lot of people ask about the maintenance. The maintenance of this implant-supported bridge is the same as a bridge that's on natural teeth.
Right.
Toothbrush, toothpaste, water pick.
Okay.
That's your primary form of maintenance. And of course, we like to check a person once they're healed, and all of the restorate, we prefer to this as the restoration or the prosthesis. And once it's completed and we have instructed the person on how to keep it clean, sometimes we only have to check a person once a year.
Okay.
And most people keep these things squeaky clean.
That's good. That's very nice. So the next slide here is a lower hybrid, as you mentioned earlier. Not everyone has to do the full mouth. It really would depend on their individual needs.
Right.
And if they have some good, healthy, natural teeth, we're going to encourage that they keep what they can if it's makes sense.
If it's
to
feasible.
Keep. We're correct.
Right.
Correct.
So as Shauna said, this is a lower. Basically, it's the same thing, but more onto her comment. People ask, well, do I have to do the entire thing? And the answer is no. We have some people who come in and they're perfectly happy with their full upper denture.
Right.
And they've been hanging on to lower teeth their entire life because they've always been told you don't want to lose those teeth because the lower denture is going to be miserable.
Miserable.
And so they get to the point that they're going to lose those teeth and they're horrified. And so we do some of these where they keep the upper denture and we do the lower implant bridge.
So the great thing to know is that there are options, and we're going to get a little later into how someone can find out what they're a candidate for, but it's good to know that you have options.
Right. You
when it
always
comes
have
to
options.
replacement.
And if a person comes to us with a mouthful of good teeth, I mean, we identify that and tell them they're in the wrong place.
Yeah, absolutely.
And there are people who come with a mouthful of good teeth, but they have severe periodontal disease. And so something that the viewers might not understand is you can have good teeth but bad tooth support, which is the periodontal disease part. Or you may have every tooth in your mouth may have such bad tooth decay that it's not feasible to fix them, and you have perfect bone support. So there's no certain way that individuals come in. We see, everything that can be seen, we
Right.
see. People that have a lot of bone, people that don't have any bone, people that have been 4, 5, and 6 places
Right.
looking for a solution, only to be told they don't have any bone.
Right.
And they somehow end up here and we're able to take care of them.
So then the next slide here is one of your existing patients, and she's such a sweet lady. Tell us about her.
Well, she comes from over east of Lakeland, and she was funny when we put her teeth in, and she looked in the mirror and she was very happy with all that and everything. And she goes, I want to be on one of those commercials. And so we hooked her up with Ted, and that's where she found herself on one of those commercials.
That's awesome.
And but she's one that I think we did a lower only on. And I can't recall what the situation is with the upper, whether she had upper natural teeth or a denture, but she had the lower. Is very happy.
Yes. You can tell by her before and after picture. Just getting her to smile was difficult for the before.
Well, a lot of people kind of do a makeover once they are proud of their smile and they're proud of the way they look. And of course, we have people all the time that know that if they get up to a conversational distance, that people can smell their breath. You and I were just talking to that guy the other day, and he goes, I'm always chewing on a mint because I know my breath stinks and I don't even want to get up close to people.
Yeah.
And when all of that disease is gone and they look good and they know that their breath is good, it just is a whole different lifestyle for them.
Absolutely. More confident. They feel better about themselves. They definitely lose that embarrassment. So let's move on to, what makes New Teeth Now, our facility, different?
Well, we have a business model. We used to have a slide. I don't know if we have it. It shows a more traditional oral surgeon's business model. And the typical business model is that you would go to the surgeon's office and, first you would go to your dentist and you would see your dentist. And they would say, well, you're losing your teeth. You need to go see the surgeon to talk about implants. So you would go to another office.
Right.
And you would meet the surgeon and they would talk about doing implants. And then that doctor, the surgeon doctor, would communicate with the restorative doctor. And then they may bring in a lab, who's now a third business, come in and talk. And so then they decide they're going to do this, that, and the other. And you find yourself, having the surgery in one office, and then you may have to get up and drive to the other office. And then you've got the lab, and so you don't have everyone all gathered up in the same place.
Right.
And that works pretty well when you're doing simple things, like a single tooth replacement or something like that. But when you're doing complex restorations, it helps, and we recognize that early. And the first thing we did was we assembled a team where we had our restorative dentist, our surgeons, and we have an anesthesia department, which most people don't have. We also recognized early on, because we did so much of this early on, that local anesthesia and IV sedation, even moderate to deep sedation, just really doesn't work that well for these complex full mouth procedures. Maybe we're doing zygomatic implants and some more advanced techniques. So we transitioned to doing general anesthesia, where we put a breathing tube in and our patients are totally asleep. So we brought that concept in to our business model, to where we had the surgeons, we had the restorative dentist, we had the anesthetist, all in one building. And
Very convenient.
yeah, things flowed really well. Well, we were using a local outside laboratory, and we were beginning to do so much of this kind of work that we were overwhelming the local outside laboratory. So in 2013, we opened our own in-house lab. And so now our business model consists of the surgeons, the restorative dentist, the anesthesia department, and a full laboratory that is dedicated probably about 99% to this type of restoration only. And so that's how we're different. Almost no one has this business model.
Right. So a patient can come here and have new teeth now, see the surgeon, the nurse anesthetist, the restorative dentist. Their teeth are made right here, and they're never sent to another facility for
That's
new
correct.
teeth now.
And they can return here for their maintenance. Afterwards.
Yes, that's
And
very convenient, and it makes us very unique.
we're very unique, and we see people from all over the country, actually. Someone will see a commercial. A lot of you have seen our TV commercials that run locally, and someone who lives in the I-4 corridor will see one of our commercials, and they'll call their sister who lives in Alaska and say, you know, you need to get down here and get this done.
Right.
And so we've had people come from all over the place. And, you know, it's a vacation destination, so that's worked out well for some people as well.
Yeah, absolutely. So our operating rooms here are designed for patients to come and have an outpatient surgery.
Right.
And it's safe, backup generators. I mean, we are equipped like a hospital, basically.
Yeah, our office was built originally under the supervision of the Agency for Healthcare Administration to be a licensed ambulatory surgery center. And so anyway, as Shauna said, yeah, we have an automatic backup generator. In Florida, you know, you get an afternoon thunderstorm
Yeah.
that pops off the electricity, and the generator comes on automatically. Or if there's a traffic accident or whatever. And, you know, most oral surgeons' offices just don't have that. But we may have 2 people under general anesthesia, and we can't afford to not have that.
Right.
And so that's a huge safety factor in terms of having backup suction or backup, you know, vacuum or whatever you need. So yeah, we have incorporated all of those things.
Right. We're providing the safest environment that we can for our patients under a general anesthetic.
You can't get any safer. It's no different here than any other licensed ambulatory surgery center.
Wow, that's wonderful. Let's show the next slide, which is a picture of our facility, and we will continue on in our presentation. There is Florida Dental Implants and Oral Surgery, where we do the procedure New Teeth Now, and it's been a process to get this building where it is. I remember when it was not 16,000 square feet.
Right.
And we've had some new developments when we brought in the lab and Dr. Dibbs and the restorative department.
And there's been a lot of energy expended in taking, you know, our practice to where it is right now. I mean, it's the best there is in the country.
Very successful.
And it just is.
Yes, sir.
You know.
How many cases of New Teeth Now would you say we do per year? I mean, this is not something we rarely do.
We'll average somewhere between 25 and 30 patients a month. So you figure 350 a year is a pretty reasonable number.
So when they come here,
And
they're getting
some of those
expert.
people have both of their jaw. The majority of those have both of their jaws, and a few have had one jaw and they're coming back for the other.
Right.
It seems like I've seen a lot of that lately, and then a few we just do one. But the majority of those 25 or 30 people are having both the upper jaw and the lower jaw taken care of.
Mm-hmm.
Yep.
So let's talk about the implant surgery, actually placing the implants. We see a lot of patients here who have a denture. Maybe you've had a denture for 30 or so years. They've been told that they have no bone for implants.
Right.
Well, we can help those patients. Why don't we talk about how we help them patients?
I love this x-ray, or they're seeing this x-ray, the viewers are, correct? This x-ray, first I just want to talk briefly about the bottom, because we have talked about these prosthetic devices that we put in as being a bridge. And so on this bottom, on this side, as we're looking at the x-ray, on the right side is a dental bridge. So that is a bridge that is connected to natural teeth. It's fixed in place, it doesn't come out, and you have to clean it with a toothbrush, toothpaste, and a water pick. In the very same position on the other side is a bridge that is connected to 2 dental implants. It is a bridge. It is a bridge. When you look into the mouth, one does not know that this bridge is on implants and this bridge is on teeth. So there is no secret deal about dental implants. They're just, they function as support teeth for bridges. So just take that a little step further and put a few more implants in the upper, and so now you have that bridge that goes all the way around from the left to the right. But back to your question specifically. Yes, we do see a lot of people who come to us by hook or by crook who have no bone. And they have been around to see a variety of people, some little name inexperienced people and some big name very experienced people who send them to us.
Right.
We are the leading placer of zygomatic implants just about in the world. Zygomatic implants are these big long things that are about 2 inches long, that when there is no bone in the back of the upper jaw, they anchor into the zygoma bone, which is your cheekbone. And we got in very early on the curve with zygomatic implants. They are a workhorse in our practice. We've done thousands of zygomatic implants. And they enable us to take someone who has no bone and give them new teeth now. These folks do not have to wait on bone grafting to heal. We can put in 4 zygomatic implants. This particular x-ray that you're seeing here, this person had enough bone in the front for traditional implants and 2 zygomatic implants in the back. But we also put in 4 zygomatic implants when there is no bone in the front and no bone in the back. So that is just another thing that we do. It's done so routinely that we hardly even give it a second thought anymore.
It's routine for us, but for our viewers, hearing about implants going to the cheekbone, they can sometimes be a little hesitant about that treatment. There's no greater risk, though.
Well, when you consider the alternative is to undergo some sinus grafting. And typically we're talking about folks that don't have any bone.
Right.
And sinus grafting is not as successful in those people that don't have any bone. And okay, so you graft the back and you lift it up, but it's still narrow, it's still skinny. And so even though you have lifted up the sinus, you still have this skinny ridge that you can't put traditional implants into.
Makes sense.
Because it's knife edged.
Right.
And also they may not have any bone in the front. And so, okay, we've lifted the sinuses, now what? You still can't have all of the implants in the back.
Correct.
You can't have all of the implants in the front. You got to have them spread around to distribute the force. And so zygomatic implants, number 1, require no bone grafting. Number 2, if you have trouble with one, you just take it out and your trouble is over. It's not like your sinus is full of bone, cadaver bone that would have to be cleaned out.
Bare bone.
Right. So no bone grafting, no waiting. Teeth can be attached the same day. We've done thousands of them and they work really well. So there is no negative to zygomatic implants, because people who need that type of treatment they are at the end of the line. There is no one else who will take care of them.
Mm-hmm.
So we're just lucky that we have
We are.
Zygomatic implants.
We absolutely are. Yes, absolutely. We haven't spoken about a recovery for someone who has new teeth now, but it would be, a typical surgery recovery with maybe some bruising and swelling, minimal discomfort, moderate maybe. What about with zygomatic implants? Would they have a different recovery?
No.
No.
Maybe a little bit more swelling up around the cheekbones, right up in here. But in terms of bruising, the level of discomfort and that type of thing, I have not found there to be any more or less. It's just kind of the
That's
way
what
it
it is.
is.
Yeah.
I would say that in general, as you said a while ago, that in general, people who undergo this procedure are shocked by how little discomfort there is.
Yeah.
Consistently.
Right.
Not occasionally, but consistently shocked.
When I see patients in a consultation or when I'm prepping them for their surgery, I'll oftentimes tell them, I'm preparing you, for surgery, but you're most likely going to call me and tell me it was way easier than what I prepared you for. And patients are shocked that they do so well. This next slide here is comparing a mini implant to a traditional implant. Now, we don't do mini implants here.
We remove many implants here.
We do.
Yes.
We do. Yes.
Minis are typically placed by less experienced practitioners, and sometimes mini implants are asked to do above and beyond what their intention was, and so they just don't have enough strength. They're not bonded to enough bone to withstand forces, and they loosen.
Mm-hmm.
But you can see in the two x-rays up here where the arrow is, they're very tiny, and over here is a more traditional type of setup where the traditional implants are tilted in front of the sinus. We're able to do this sometimes as opposed to zygomatic implants. So this tilted technique is employed all around the world, and it's a widely accepted, extremely successful and easy type of technique.
Now, the technique for tilting the dental implants in the upper, we're obviously avoiding the sinuses.
Right.
But in the lower, I see tilted implants. Why is that?
Well, we're avoiding the nerve that runs through the jaw and then comes out of a hole in the jaw. Right about at the corner of a person's mouth, there's a hole in the bone, the nerve comes out, and so we're able to put the working head of the implant here, and if that went straight down, it would be either in the nerve or dangerously close to the nerve. But by tilting it anteriorly, we can still keep the working head of the implant here, but the body of the implant more anterior and away from the nerve.
Yeah. So we're able to evaluate a patient preliminary, which is a consultation, and we're going to talk a little more about that later, but we can treatment plan for the patient where we would position and place their implants around their sinuses, avoiding their nerve, and know whether or not they're a candidate right away.
Right, and we can do that from the CT scan,
Right.
which is a little bit more of a sophisticated x-ray than a traditional flat x-ray.
Panorex. The next slide here is going to talk again about zygomatic implants, and we talk about zygomatic implants a lot because I'd say probably 50% or more of our patients need them. Again, they've changed our practice.
I'd say 8 or 9 out of 10 upper jaws we place zygomatic implants, maybe at least one. Now this slide shows the
4.
so-called quad zygoma technique. So there's 2 zygomas on each side. Now in this particular slide, it's combined with 1 implant in the middle. In the middle slide, you have 4 zygomas combined with 2 in the middle. And on this slide is just 4 traditional zygomas where there is no bone in the middle. So it is a versatile technique, and sometimes we employ traditionals with zygomatics, and that is purely an individual variation. The other thing that this slide points out is it shows the little nerve hole, and it shows how tilting the implant moves the body of the implant away from the nerve hole. And the nerve comes out of that hole and branches out and to supply the feeling to the lower lip and chin. So even though a person's face would not be paralyzed, it would be numb.
No.
So it's very important, when possible, to at all cost avoid that nerve.
Mm-hmm.
Yep.
Yeah, obviously that's very important when we're looking at placing dental implants. There are obviously some minimal risk involved, but we're able to talk about them and talk about how we can work around the nerve and the sinus. So we're going to move on in our presentation and show you some slides of our staff. This is your awesome surgical team.
Right.
Your young ladies who help you with the procedures, and they help your patients feel comfortable and can answer surgery-related questions, help them with post-operative questions. You just have a great team.
They're a good bunch of good gals, absolutely. Yep.
They've been with
Very
you a long
caring
time.
and experienced, and of course Shauna's been with us for a long, long time, and is one of our implant treatment coordinators, and you can probably see her picture here in a minute.
Yes, you will. And I was a surgery assistant
Right.
for a long time, which I think has helped me do what I do now, being an implant coordinator. So we did talk about the type of anesthesia that we provide, and we do have our team of nurse anesthetists who come in and provide the service for our patients. Jack and Kim, you want to elaborate on what they do? Or
So the initial CRNA means Certified Registered Nurse Anesthetist, and so these are all, they're nurses that have advanced training in anesthesia. Nurse anesthetist is someone who typically, after nursing school, worked in like SICU or ICU or CCU for a while, and then was accepted into a nurse anesthetist training program, and those are 2 or 3 years where they work under the anesthesiologist for some period of time, and then they become a nurse anesthetist. So anyway, they can practice in Florida, because we as oral surgeons, and I did a year of anesthesia and have been doing anesthesia in the office for going on 38 years, and I figured at the last webinar when we were here, we got to thinking about that, and I figured that in 37 years, and I probably have done about 2,000 a year, so you can do the math on that. I've probably done about 75 or 80,000 anesthetics over 38 years. And so these people, work with us. It's not like we're inexperienced.
right.
These people are very experienced, and so what we offer in terms of anesthesia is as good as it can get. And you remember I said earlier, we get medical clearances because you have to understand that most of the people who come for these procedures are not in their 20s and 30s. Okay, most of the people are in their 60s and 70s.
Right.
We see a few in their 80s, a few in their 90s, but most of the folks are in their late 50s, 60s, and 70s. And so we get medical clearances on everybody. We get lab work, cardiograms, just like would be done in a hospital setting.
Mm-hmm.
And so we deliver, in my opinion, is the anesthesia here is extremely high level.
I agree. We do have a question. Someone would like to know if they could start this procedure with just their bottom.
Yeah.
Can they replace just the bottom?
Absolutely. The only time I'm a little hesitant to do that is if somebody has like advanced periodontal disease and a lot of infection, let's say with the upper teeth.
Mm-hmm.
And so you have all this bacteria and everything in your mouth from the upper teeth, and you want to do implants on the bottom. I mean, it just kind of puts the lower implants at risk, in my opinion, a little bit, because you're putting these implants into a mouth that's really not as clean as it should be.
Sure.
But if it's an upper denture, there's absolutely no problem with that whatsoever.
Mm-hmm.
Yeah.
Wonderful. So if someone did start with their bottom and they weren't happy cosmetically with their upper teeth, does that pose a problem?
Well, if they're not happy cosmetically with their upper teeth and it's a denture, it doesn't pose a problem,
Right.
because we just make
A new one.
a new upper denture.
Yeah.
If they have natural teeth and they don't like the way their teeth look, then they have several options. Orthodontics. Some people, and we've tried to lead people
Correct.
who have good teeth that are sitting in good bone. We are not taking those teeth out, okay? We're sending those people to the orthodontist or to restorative dentists for veneers or crowns or whatever. But so yeah, I mean, if you have yellow upper teeth and you want to have nice white teeth,
Right.
and you don't want to have these implants on the bottom and then have yellow teeth on the bottom to match your yellow teeth on the top, then you can do some bleaching, you can do veneers, can do braces to straighten your teeth, and then do veneers.
Right.
So there's things
Again,
that can be done,
Options.
or a new upper denture if need be.
Okay. So the next slide here is just explaining again our on-site dental laboratory. Our teeth are fabricated right here, right from the temporary bridge that's going in the day of the surgery, as well as once a patient has fully healed and we make their final bridge out of the zirconia. So this slide here is showing how it's mounted, I believe.
Right?
Okay. On an articulator.
Right?
Okay.
You're
see?
exactly right.
I do know something. I'll let you take over and talk about what they're looking at.
Well, I think for the viewers, what they need to understand is everything is just done like that slide says, on site right here. We're not sending anything out to China or anything like that.
Right.
So we have Dr. Dibbs, who's our restorative dentist, and we have Dr. Nafala, who is a local dentist who is here part-time. He is also a restorative dentist. And so they have at their disposal their own private lab, which if you listen to Dr. Dibbs, and some of these webinars, we let Dr. Dibbs talk. Most of the time we keep him stuffed away in a corner. But sometimes we'll let him talk a little bit, and he will tell you that from a restorative dentist standpoint, having your own lab at your disposal is just like a dream come true. And so that's what he and Dr. Nafala have. And so by that, we have quality control, and we're not having to deal with an outside entity.
Right.
Everything's done right here.
Which is really nice for the patient. I know patients that I work with, one of the things that they've said is, I was able to meet Terry,
Yeah.
the person making my teeth. That is very convenient for the patient, for the restorative dentist, and for us providing the service.
And for the team, Terry and Mike, a lot of times at the end of the day, they like to come down and see the result of their work. And so that's something that a dental laboratory technician who's stuck over on 3rd Street, back in a room doing something, they never get the opportunity to be involved with the person that they're making the stuff for. And so being able to work in a lab that's associated with the practice and the surgical team and the restorative team, it makes their job so much more rewarding because they feel like they're part of the team, and they are.
They are.
Yeah.
It's definitely something to be proud of. Some of the teeth that I've seen are absolutely beautiful.
Yeah,
and
they do a great job.
Yes. So this slide that you're seeing now are 2 bridges, and one is acrylic and one is zirconia.
Right.
Go ahead. You can explain them.
You're wanting me to explain everything.
I do. I like it when you talk. There's so much education coming from you and wisdom.
Well, the top is the zirconia, and it is going to be glazed porcelain. So it's very tough, and it's impervious to stains and odors. Whereas the bottom set of teeth is acrylic, and the acrylic is more porous. Plaque and tartar will adhere to it, it will hold stains, and it will develop an odor. Not to mention the durability factor of the zirconia with the porcelain is going to wear like porcelain crowns, and the acrylic is going to wear like an acrylic denture, because that's basically the material that it's made out of. It's made out of denture teeth. Denture material versus a milled framework with porcelain. So there's really no different. I mean, there's no comparison
Right.
in the two prostheses.
Zirconia is obviously far more superior.
Absolutely.
Patients can eat a normal diet with
Absolutely.
zirconia?
Without fear of a portion of the prosthesis breaking or the teeth popping out, which we see during the healing phase sometimes with the provisional teeth. So in the final teeth, the zirconia is far superior.
Yeah.
So I'll take it on this slide.
You'll take it. Go ahead. There I am.
We have several people who are involved. If you called into our call line, you would get Shauna or Debbie. And Shauna and Debbie have both been with us a long time, like over 20 years. And they both have been surgical assistants. So they have the unique educational background to be able to talk to people, having had years of surgical experience and years of restorative experience, and they know about all of the phases of this. So they are uniquely qualified to do that. Now we have other people that answer the phone as well, like Jason, who's sitting over here, who's extremely knowledgeable, and the other people, Emily and Grace, and the other people who answer
Nicole,
the phone.
Ashley.
Ashley, who answers, who used to be one of my surgical team members and who has moved on. So, and Nicole, absolutely. So we've got about, 7 people who are like above and beyond knowledgeable,
Right.
that can answer the questions over the phone and give you stuff that you can take to the bank in terms of what they tell you.
Right.
So,
Well, all the ladies too who answer the phone, are very personable. Their goal is to make that phone call as easy as they can for the caller.
yeah.
Sometimes the hardest part is that first phone call, getting the information or scheduling
Right.
the initial visit, which is
Right.
a consultation. And so, these ladies are very good at what they do, and they would love to speak with you.
You want me to take that
Yeah,
and run
sure.
with it a little bit?
Yeah.
One of the reasons that we don't make the final teeth the same day or the next day, well, first of all, to make one of these zirconia prosthesis is a 3-day deal.
Right.
1 day to mill it, 1 day to sinter it, and 1 day to put porcelain on it. So it would be virtually impossible to make this the same day. And we have done teeth in a day, teeth in 3 days, teeth in a week.
Teeth in
We've
an hour.
done it every which way you can do. And the reason that we do it the way we do now is the direct answer to the viewer who typed in this question. Because when the tissue is reflected and the implants are placed and the tissue is stitched back up, we all know that the tissue is going to swell, and then the tissue is going to shrink, and the tissue has to heal. We all know that.
Right.
And so if they go out to Vegas and they get the teeth done the same day, and then they come back to Florida, the tissue's going to swell and the tissue's going to shrink, and there'll be maybe gaps open up under there. And maybe after 2 or 3 weeks, they're going, maybe I should have gotten whiter teeth, or maybe these teeth are too white, or something may break. So we make the acrylic teeth the same day, and we leave a little loosey-goosey in it, a little expansion joint, so to
Really?
speak. So the tissue can swell, the tissue can shrink, and then if there's some gaps, we can easily fill them in, and we have them test drive the tooth color. So they get to wear that tooth, that color, that shape, and that size of a tooth for 3 or 4 or 5 months. And if they don't like what they picked, when the final teeth are made, they get to change it to what they want. And when the final teeth are made, the gum tissue will have completely settled, so that when these teeth are made in a virtual environment, they can be closely adapted to the gum as the gum is healed. And so that's a great question. The gums do need to heal, and that is the reason we're not too quick about making the final teeth, because when we make the final teeth, we want the person to be happy with the teeth, and we want the teeth to be adapted to the gums, and the gums need to heal.
So to review before we go on, let's talk about the actual stages that a person could expect. The first stage being they're going to make that phone call and schedule a consultation to come in and meet with you and have a dental CT scan where you can sit and review their scan, look at their bone density, their anatomy, and treatment plan their case.
Right.
For that patient that is ready to move forward, then their next visit is to meet Dr. Dibbs.
Right.
And have impressions, talk about the look and color of the surgery day teeth, the temporary.
Right.
From that appointment, I would say about a week or two later, generally they're going to come to the office here about 7:30 a.m.,
Right.
go under general anesthesia. If they have teeth, we're going to remove them, prep the bone, put in the implants. They'll have a private recovery time. Prior to discharge that afternoon, their new temporary bridges are attached to the implants.
Right.
We obviously would adjust their bite, maintain things, monitor their healing.
Right.
We limit their diet somewhat
Yep.
during that time. And then after they've healed 4, 5, or 6 months, they're released back to Dr. Dibbs. He's going to go through a series of appointments, allowing them time to make cosmetic changes, and then they're going to go into the final zirconia.
The final teeth. Right.
So that's pretty much a review of what a typical patient
Right.
could expect
Right.
throughout the process.
I think probably after the initial surgical procedure, there's about 3 post-operative visits, and then they're released to Dr. Dibbs. And depending on what needs to be done, there's another 3, maybe 4 visits with Dr. Dibbs to get the final teeth. Because Dr. Dibbs goes back to the ground level, all new impressions,
Right.
because we're picking up the tissue as the tissue is then. It's healed, so the contour is different, so we pick that up. And then he typically will, make the changes that the person wants to make.
And basically that bridge is just going to kiss up to their natural gum. It doesn't sit over it like a denture. It's not going to pinch the tissue. It's just going to kind of be formed to nicely kiss or hug that natural gum.
Just like a bridge on natural teeth does.
teeth.
Yeah. But what Sean is saying is correct. There are no big open gaps, and it's not concave over the jaw either. It's just kind of going up there and kind of touching it.
And when they smile, that junction there
Yeah.
should not show, correct?
No, the junction's still up under the lip,
Yeah.
so
So
nobody sees the junction.
We want them to show the teeth and it look as natural
Right.
as possible.
Right.
The next slide is going to show you what we do when you come for your consultation, which is the CT scan, which is an open scan. And very easy. It takes about 8 seconds to actually get the CT scan that we need to treatment plan the case. Other than a little bit of chirping noise that's associated with it, it's a very easy scan. No reason for anyone to feel claustrophobic or afraid of that part of the consultation. And then our CT scan generates multiple ways that we can look at the bone and the anatomy.
Right. Sure does.
We can look at it straightforward in a more 2-dimensional view. We can look at it in a 3-dimensional view. We can look at slices of bone.
That's right.
And that's what you're seeing right now. And this is what we would actually be able to show each patient in their consultation and really explain their own bone and anatomy.
Right.
So this is a lady that had a very significant change, I think. I mean, before, she's not smiling. She doesn't look very happy. And then you can tell she's definitely had some form of a lifestyle change.
Absolutely.
Yeah. She has great results.
You could look at any one of a number of people. Almost everyone does sort of a self-makeover.
Yeah.
I mean, we've all seen it.
My dad has had this done.
Yeah.
And he does a lot of public speaking.
Oh, yeah.
And so from, someone who does this as a job,
Yeah.
I learned to appreciate my patients and the patients that we work with, but then seeing it help someone that I truly loved
Yeah.
You know, that was a testimonial in itself
Yeah.
about what New Teeth Now can do for
Absolutely.
someone battling periodontal disease. This is a fun guy.
He's a nice fella from
Yeah.
just up the I-4 corridor from us, and just a nice guy. He just had advanced periodontal disease, one of those situations where he had been to the dentist his entire life and had been going to the gum specialist, and you know, I think they just told him, hey, we're losing the battle.
Yeah.
You know, got to go in another direction. And I can't remember exactly how he found us, but he's very happy with his result.
What's nice too is he's willing to talk to patients about his experience and answer questions that someone like myself or yourself who's never
Yeah.
actually had the surgery
Right.
can answer.
Yeah.
So that's, you know, a great resource to have patients who have had the procedure and been through the recovery to be able to share their experience. If you viewed this webinar, then you most likely have a true need for dental implants, and the next step is calling for a consultation. Again, we have some fantastic ladies here who are ready to help you, and we hope that we can help you through your New Teeth Now journey. Have a wonderful night, everyone. If you would like to view more informational videos on New Teeth Now, please click the subscribe button here. Thanks for watching.